Hi, my name is Melanie Welch. I'm a physical therapist with several years of experience with amputee patients at every stage of their rehabilitation. I've been here with Dayton Artificial Limb for 3 years now, embedded in this prosthetic practice, and as we've gone along, the prosthetist and I have discovered that we each bring different viewpoints on fitting the prosthetic patient, and that we complement each other's knowledge to bring our patients the best possible outcomes. I'd like to begin this presentation with an overview of physical therapy, the evaluation and the treatment, and then we'll proceed to some specific instructions for the elevated vacuum patient. On the first day that I see a patient, I'll be performing a physical therapy evaluation. When most people think of physical therapy, the first term that they think of is range of motion. And indeed, that's usually the thing that I start evaluating with a new patient. Specifically, I'm looking for hip and knee flexion contractures. Also, range of motion of the sound side ankle. We know now that a patient needs to have at least 4 degrees of dorsiflexion to have good balance. And we find that this is often lacking in our patients. So we want to check out the sound side as well. The next part of the evaluation is for muscle strength. In addition to upper body strength, I'll be specifically looking at hip extension strength, particularly for the above knee amputee. We know now that hip extension strength is really the key to success with an above knee prosthesis, and so we'll do the manual muscle testing for this as well as the remainder of the lower extremities. I want you to raise this leg up toward the ceiling and hold, don't let me push it down. Good. Other side, same thing. Raise up and hold, don't let me push down. Good job. The next component of the evaluation is balance, looking at single leg stance time and other aspects of balance so that I know what assistive device the patient will need to be safe. Then I'm looking at the area of mobility or functional activities of daily living, how well they're able to get in and out of their bed, transfer to their wheelchair, what kinds of things they're used to doing at home. Is this somebody who's been sedentary for a long time versus somebody who's used to keeping up their own household? All of these things will play into how we set goals for this patient. Additional components of the evaluation would be an assessment of the patient's pain, what type it is, how intense it is, how well it's controlled with medication. Phantom pain is a very common complaint in amputee patients, and I try to give them several helpful hints on various ways to manage this. Skin integrity is an important component as well. There are many different kinds of skin issues which come up in the fitting of a prosthesis, and so we want to know what their baseline situation is with that. Then of course we'll be looking at their gait, however it is that they come to us, whether they're still hopping with a walker or whether they're already begun the fitting process. Specifically with gait, I'm looking at what kind of assistance or how much assistance they need, how far they're able to walk, various gait deficits such as their base of support, their step length, their posture, trunk movement, arm swing, etc. All right, take your time. Good. Other things that I may look at depending on the situation would be their medical history and how this would impact their recovery and their learning process. Many of these patients have other medical complications which need to be taken into consideration. I'm looking at their cognition and their ability to learn and retain information, their home situation, family dynamics. All of these things play into a patient's eventual success with the prosthesis. Another evaluative tool that I might use with our amputee patients is the Amputee Mobility Predictor. This is a functional test developed by physical therapist Robert Gailey several years ago, and it has since been shown to have good reliability and validity. Its primary use is to help determine K levels, or functional levels, for the amputee patient, and its results are accepted by Medicare as objective information for this use. Other uses for this test are to help set goals for therapy to determine what physical systems need to be addressed. Also to predict walking distance. It has a very good correlation with the 6-minute walk test. And to help measure change over time. Oftentimes I will do a test near the beginning of the rehab process, and then again after a certain number of weeks, and then perhaps again at discharge. Something new that we have begun here at Dayton Artificial Limb is to use this test pre and post elevated vacuum, testing the patient in their old prostheses first and measuring that K level, and then testing again a couple of weeks after they have been in the elevated vacuum system, hoping to show some functional improvement with this new socket system. When it comes to treatment, the physical therapist will always begin with therapeutic exercise. The best case scenario is when I'm able to start working with the patient before the prosthetic fitting process even begins, instructing them in exercises to address strength, range of motion, and balance problems discovered in the evaluation, and often including a home exercise program which they are encouraged to perform daily. I'm instructing this patient in a bridging exercise to strengthen her hip extensors. The other code that I most often bill for physical therapy treatment is prosthetic training, which would encompass every aspect of treatment once the patient is actually fit with the prosthesis. These would include instructing the patient how to don and doff the prosthesis, including use of the vacuum pump in the elevated vacuum patient. It also includes proper hygiene, care of the liners, sheaths, socks, and how to use them to customize the fit. Helping the patient to create a wearing schedule that fits their lifestyle. Also weight shifting and other balance activities in the parallel bars, advancing to prosthetic gait training. We know that prosthetists teach a lot of these things also, but you know that most patients need the repetition. For the elevated vacuum patient, one of the most important things that we begin with the patient is instructing them in the donning process. The prosthetist will often go through this with the patient once or twice as they're doing the actual fitting, but this is a more complicated donning sequence than a simple pin system or other suspension methods. So we do a lot of repetition with this, and we've developed a printed handout, which I believe you have a copy of in your folder. It's interesting that even patients who are low cognition have been able to develop sort of a motor memory, as this is a hands-on skill, and succeed with this, as have patients with low vision and other special needs. The primary difference in gait in the patient in elevated vacuum is that these patients are more comfortable right from the start and generally don't complain of pressure in any of the usual places. When they are pain-free, then they willingly accept more weight onto their prosthesis, and this almost always results in a more normal gait. In addition, since they can wear the prosthesis for longer periods of time without worrying about skin breakdown, they can practice more at home, which leads to faster improvement. Once symmetrical weight shifting has been established, the therapy can proceed more quickly to other areas, such as normalizing the pelvic biomechanics, facilitating trunk motion, and other components of gait which lead to efficiency and a normal appearance. This patient was only fit with his vacuum system prosthesis 4 weeks ago, and he's now ready to transition away from the cane. I haven't really noticed any specific differences in gait due to the elevated vacuum system other than what I've already mentioned. I know Bob Gailey feels that the primary difference in efficiency and energy return has more to do with the prosthetic foot than the actual socket system. Again, the differences would be in comfort and in weight acceptance.
Now that I know how to do this, this kind of feels like a hand in a glove.